inviting me to this talk. I don't know how the algorithm that selected me to give this talk. I don't think I'm in the best position. Not that I cannot speak about KNT from now till evening, but tomorrow. But this is quite a topic that is somewhat challenging. Sorry, I'm trying to open the slide. And okay, I'm on my camera now. Yes, and it's not really your typical textbook topic. I remember when I was preparing the topic, a colleague saw me and said, "Why you stressing yourself?" You never really find anybody that will talk about management of pain yet. The closest I got was paper, and I almost paid for the paper to see what is inside, only to find out that it was talking more about the management of pain post-operative in ENT. So I want to believe that the society will be more interested in my perspective and not some complex pathophysiology of pain or some other complex issues. But I assure you there will be gaps. And the solution to that is that they will have ample time to make your contribution. If I become, sorry. Okay. So, like I said, there are so many dimensions at which you can look at pain in ENT. Of course, it could be a primary complaint, and we'll dwell on some of those cases here. Of course, any patient that has direct trauma will have pain, and that's pretty straightforward. Sore throat is quite common in ENT. Of course, if you have surgically, patient will have pain. So pain could be a consequence of our procedures and procedures. And also we have headaches and facial pain. I will try to avoid this as much as possible. I believe headache deserves its own more than a webinar. I won't talk a whole section on its own, and it's quite an extensive topic that straddles so many specialties. It's actually more specific syndrome. It's only makes more sense when we combine it with other information. And it can be, that's what we call diagnostically low yield symptom, because it does not really tell you so much. From now, just permit me once in a while to interchange head and neck with ENT, because we try to use them, not exactly the same, but they are interchangeable. And sometimes. And inflation will also be challenging to patients. Patient will tell you, I've been patient for 2 years, but because of the possibility and tightness of the space, they are actually tying the space that all fears which may be unrelated to the present pain and forgetting the intervening period of the given. And also, naturally, in the presence of pain, a serious pain, we tend to suppress other symptoms. So I made this little orbit so that we can understand the division of these challenges of pain. So subjectivity is that patient cannot really pinpoint, like I said earlier, where is this pain coming from. If you look at the picture, is this of the pictures on the slide?
Hello, Doc. We are struggling to hear you. Is it possible to find something to the audio, or you may probably remove the video if the network is bad?
Video. Let me remove the video. Okay. Sorry, where did I lose you?
Well, just continue. Yeah, we can.
Okay.
Maybe the previous slide. Previous
slide.
slide.
Okay, this slide or this.
This one. Pain makes more sense. Yeah.
Okay. Yes. I said pain anywhere in the body generally is diagnostically low yield because you don't make sense of pain until you have some other information. And that is what I call diagnostically low yield symptom. And I said earlier that I may use head and neck sometimes to refer to this region of pains and throats once in a while. Just permit me to do that. And the reason is that pain make it derive more from it. You need to have the exact location. That this is basic clinical medicine, and this may be challenging in this region. Of course, the duration, as simple as it is, patients tend to link in our own practice. They link an older pain with the current pain because they feel they are related. One patient who had pain 2 years ago will come and tell you, if you ask when this pain, when this started, tell you 2 years. But the pain will be beyond it. They practically forget the intervening period of relief, and this and the pain are not related because the anatomical sites appears to be the same, but not quite. And of course, patients may suppress symptoms in the presence of pain. This is natural. If you have pain, you don't think about any other thing. Think about relieving that pain first. But I said these challenges, I try to put them in a circle so that we can talk more about them. And so let's just talk about them. Sometimes it's difficult for patients to pinpoint exactly where the pain is coming from. If you look at the pictures, you will be right. I hope I'm still on you. Hello? I hope I'm still on you. Hello?
We can hear you.
Okay. Sometimes patients I'm trying to shout into the computer. Patient cannot really pinpoint where the pain is coming from. If you look at the graphics we have up there, you see that you'll be right. If you say the pain is coming from the ear or the mandible or the parotid or the hair or the sinuses. So it's difficult for patients. And when you are asking them questions, they will just put their hand where they feel they have the pain. And I see this almost every day in my clinic, that you ask the patient where the pain is coming from, and they swipe their hand from the neck to the hair to the jaw, and you are confused. Of course, examination is not actually helps you in this case because it may not make sense of the location. According to the patient. On this, the structures in this region are really tightly packed. They are very complex. And innovation is resounding.
Hello, Doc. I mean, can you try this? Can you try the one that you muted and let us see whether the audio quality will be better than the one you are using now? I know you joined through 2 devices. So you muted one and then you are using one for speaker because this one is fluctuating between audible and inaudible. You have muted everyone now. All the two. Can you?
Hello? How is
Okay.
now?
Looks better.
Sorry, I'm going to ask about, is it better now?
Not quite.
What about like this?
Okay, a bit better.
Okay, yeah. It's still the same. The one I muted is the laptop does not have a microphone. So
Oh, okay, okay.
that's why. Yeah, just for me to, okay. So I said writing on this, we know the structures in this region are tightly packed. It's like one tight box. And then the innervation can be very complex and overlapping. So you can imagine a simple structure like a tympanic membrane is supplied by nerves that come from disparate origin. And that is why you see when you are cleaning your hair, you can have this cough reflex. So easy, and especially in the external auditory canal, you have this cough reflex. So this actually makes them much more consistent in another region, but actually felt more in the hair. Okay. Okay. So, of course, patients who have other health conditions will often ask themselves, or you ask yourself, which one do you tackle first? Is it that you tackle the fire, which is the pain, or sorry, you tackle the alarm, which is the pain, or the fire, which is the disease? It may be very, very simple in most cases, but when it comes to head and neck, it may not be that direct. And then we shall have balance. So you have patients who have maybe otitis externa, malignant one, and they are more focused on the pain. You are thinking about the fact that we cannot control this infection, we cannot control the blood sugar, and but the patient's only problem, as far as it's concerned, or the main problem, is just the pain. Of course, in as much as pain will have subjective components, describing pain may also be challenging. All the things we are taught, aching, piercing, peppery, may not really make absolute sense. In fact, some patients will just tell you they feel something is stuck or something is swollen. So they feel something is swollen where nothing is swollen. And that is, hello? I hope I'm audible. Yeah, they feel something is swollen where nothing is swollen. So, and also remember that some of our patients have difficulty or child disability with regard to speech. And if there's any language barrier, this is what I face where I have, then it makes it more difficult. The only cardinal factor is that the patient is not happy when there's pain. And so you can see that patient is not feeling too good about a particular part of the head and neck. So you can always use whatever other technique you have to really understand the pathologies. But actually understanding what can happen in those regions can help you in making a diagnosis. Of course, all the pain I've mentioned so far, all the challenges, sorry, when you have them, you can now multiply them by any factor, and you know in children, you have much more problem. Sometimes you don't know what is causing them the pain. So you can be or the situation, you can see the clinician holding the syringe and the child grabbing the head. So it could be past experience. So these challenges are in pediatrics. So we need to consider this when dealing with it. And sometimes they cannot really express that they are feeling pain. For example, a child that has not had speech will not tell me he's having pain, will just be irritability. So for this presentation, we'll try to still break it down to ear, nose, and throat. But I want us to bear in mind that pain in one region can actually point to pathology. Number one, may not be limited to that region alone, because we are the ones that are respecting these boundaries, and may actually cause pain simultaneously I mean, I'm talking about pathologies in 2 regions at the same time. Or more than 2. So I'll talk about my favorite pain, and that is otalgia, and that is ear pain. It's my favorite because automatically when a patient has ear pain, we see this commonly too. They assume that the problem must be ENT, and there's nothing you can say that can convince them otherwise. It's understandable that ear pain should be directly relatable to the ear, but this is not quite so. You can see on the board we have the T's of otalgia. All the structures we have on the slide there can actually send pain signal to the ear. There used to be 10T. I can't remember the 10T. Maybe somebody will remind me. When we're in residency, we used to have this 10T. But papers or studies have been done now that there are even more structures that may not have T's in their name that actually send pain signal to the head. And there's publication on that. So it can be quite challenging for the patient that, oh, your hair is normal. That you don't have any problem in the hair that you have to elsewhere. I used to go about, I had my digital otoscope, and that's for looking into the hair, but it was difficult for me to be taken to clinic. I actually bought a portable one because it was causing so much argument between me and patients to let them understand that their hair is normal when they have referred hair otalgia. And in my own setting here, they assume that once they have that pain, there must be inflammation, and this leads to wrong management. They insist sometimes that they want antibiotics because they assume they have infection. That's why they have ear pain. So this is my attempt at a simple go-to algorithm for dealing with otalgia. Is not exhaustive, but this is what we commonly see. And then we talk about them. I highlighted some in red so that we can just pick 1 or 2 and then discuss. I'll talk about Eagle syndrome. It's actually named after a white-winged eagle, MT, American physician. Has no relationship with the bird eagle. And this is caused by symptomatic elongation of the stylohyoid process, or some people will say calcification of stylohyoid ligament. Depends on how you want to look at it. And patient will present with chronic ear pain and throat pain. Remember, I mentioned that this pain may not be limited to one area alone. So this finding classified or stylo process may be found incidentally on CT. But if patient is asymptomatic, we do not make diagnosis of Eagle syndrome. And naturally, you can see. So, am I not again? Hello?
Hey, your audio is breaking. It's breaking in and out.
Wow. I never had this problem before. Okay. Maybe I will stop one of the presentation. Maybe they are stressing my network.
If
that is what you wish, fine.
Hello? Hello?
Hello?
Okay.
Hello?
Okay. Yes. Am I audible?
Yes.
Okay. So, like I said, Eagle syndrome is the elongation of the stylo process or calcification of the stylohyoid ligament, and named after white-winged eagle, American physician, and it has no relationship to the bird. So, and this calcified process impinges on the nerve and patient and neurovascular bundles, and patient will present with chronic ear pain and throat pain. Of course, naturally, examination of the hair will not reveal any pathology. And this finding, sometimes people find this incidentally constitutive, but if it's not producing symptoms, then you don't make that diagnosis of Eagle syndrome. So, like I said, this process actually impinges on the neurovascular bundle and causes pain and discomfort for the patient. Now, I also chose hypopharyngeal cancer. Potentially, actually, all the neck and neoplasm can cause ear pain, among other symptoms. And this is just logical because this is a closely packed space, and pathology will not definitely respect boundaries. And going outside this boundary may, whether within this boundary or outside, we may have a situation where any of these structures that can send pain signal to the hair will be affected. But because the patient can presume it's very short to get in for a while. And if you look at the real distance between hypopharynx, which is down there in the head, and the hair, you will not link it together if you don't have high index of suspicion. And this symptom this will happen very early in the cancer. So it's mediated by nerve. This is a division of cranial nerve. And they will have other malignancies, generally will have other symptoms that will be very obvious. But in this case, this may actually be the early symptoms that you have in this patient and may not have any other symptoms. So that is why it is very important. So another pathology is otitis externa.
Please, the patient will need oxygen.
What? Hello? Hello? Are we still together? Hello? Hello?
Hello, we can hear you.
Okay, ma. Good evening, ma.
Good evening. Well done.
Yeah. Thank you, ma. Okay. So another pathology we can have is otitis externa, and of course, otherwise known as necrotizing otitis externa. And when you have we tend to think about this. Of course, other examination findings will corroborate another investigation. But the challenge here is the control of pain, control of infection, control of the diabetes. I will give an example. I once had a patient when I was in Abeokuta, and malignant otitis externa, very difficult to manage. Of course, our focus was more on the diabetes and controlling infection, but also the pain. And we were struggling with this pain, and he was not really happy. It was on admission, even in the private section of the hospital. But one day, he just called to me and I sent a consultation to our palliative care physician who's an anesthetist, and he saw him. And he prescribed his own regime, and during the next round, when I saw him, what he said still in my head today after so many years. I know he said, it is as if it is the man that put the pain here. Meaning that after whatever regimen was prescribed, he felt so much relief that he felt that it was the doctor that saw him that actually put the pain in his ear. So that can tell you the significance. As far as the patient is concerned, that pain is much more important to him than any other management or other thing was doing for him. Okay, so throat pain can be quite non-specific and can occur with other symptoms, but we will not really talk about the acute throat pain, sore throat. This is self-evident in most cases, and usually of infectious and inflammatory in nature. But many patients actually also come to our clinic with chronic throat pain, and the pathology or the origin of this problem is not really resident in the throat. Some of them already have the reflux. Remember, I'm talking about reflux with regard to they have reflux. And the solution to this is to obtain good history. And if you have access to the previous record, you will see that some of them are already visiting gastroenterologists. The only challenge you have now is to convince them also, like I said earlier, that your throat pain has something to do with diagnosis you have from your gastroenterologist, and we need to up the treatment or management of the reflux. Of course, other things that cause throat pain too, neoplastic process like the hypopharyngeal cancer and Eagle syndrome, like I mentioned earlier. So, well, we are doing ear, nose, and throat. We don't usually have nasal pain in that sense, but I'll talk about the situation where we have something similar. But pain in that region is usually from the sinuses and can range from inflammation to neoplasm, causing this problem. And of course, the common cause is sinusitis. And of course, sinus infection or pathologies are also closely related to headache. But let me talk about the nose. Though some authors have denied that or refuted that it doesn't exist, we call it a pseudoneuralgia. And this is an uncommon condition in our own setting. But where I am now, maybe because septal deviation is rife. And this has to be pressing on the nasal septum and irritating nerves as they enter the roof of the nose. Think around so the pain will be felt at the roof of the nose and will radiate to the forehead. And this patient will come here and point to their nose and swag their hand and tell them that if you take that place, and you look, you will not see so much if you don't keep that in mind. Of course, plastic will lead to control this, but like I said, some people are still debating that does it really exist or it's just in our imagination. But in our own setting, septal deviation is not ours common. I'm talking about Nigeria, so maybe we do not have that so much. So how do we treat? So I will not attempt to bore you. You are the pain expert. Sorry to use that, but what I like this. The balancing part between putting out the fire or the alarm. Pain is the alarm. Fire is the pathology. That is what we as clinicians must balance. And I will talk about the strategies for controlling pain, which is in your own domain. I have analgesics, local anesthetics, which may be used during procedures, topical agents. We use these during procedures, gaggles for our own procedure to control pain. Of course, we have cold compress or any other natural phenomenon or home remedies just to soothe pain. Positioning sometimes may help for sinus pain. Of course, physical therapy for jaw exercises, for TMJ, and psychological support is actually necessary because pain still remains emotional in some very degree of percentage. Okay, we also do possible injection for specific condition, like vocal cord nose noodle, and this is just to show the size. Of course, there are nerve block and there are books written on these different nerve block in here and here to control for procedure for other pathologies. And like I said, surgery may be needed to address underlying condition. For example, people do tonsillectomy and fracture the elongated styloid, stellar ligament and the size. So, and of course, sinus surgery will relieve pain. So, this is just my own attempt. Like I said earlier, this is a difficult topic. Rarely will you have us talk about management of pain in ENT. You will not really find so much out there, but I try to go through so that we have enough time for discussion. I forgot to mention something earlier concerning analgesia during surgery, or when we're talking. It's literally my teacher is Professor Amusa. I will tell you that it is only a wicked surgeon that will wait for patient to have pain before you relieve patient pain. I mean, you don't wait. Yeah, you don't wait for patient to develop pain before you start giving analgesia. So, yeah. So, thank you. Thank you for having me. I'm sorry for all the technical glitches. I thought I had 5G network here, but I don't know what really happened. Bye. Okay, thank you.
Thank you, Doc. Is Dr. Olateju available now?
I'm available, sir, but it seems your network over there is very sound and clear. You can continue, sir.
Please take over, please. We can hear you clearly.
We can hear you clearly. Please continue. We can hear you clearly. The network is very good.
In Nigeria, so something good can come out of Nigeria anyway.
Yes, sir.
Okay, so I'm right here in Ilorin, and then our presenter is in Saudi Arabia. So we want to appreciate.
We have a Professor Amusa in the house. Maybe she has some contribution.
Okay.
Who is also a consultant surgeon.
Okay, so please, Professor Amusa, thank you very much for attending. Can you make your small contribution?
Thank you so much. I'm so glad to be here. I really came to listen. I joined a little bit late, but with what I've listened to, I think it was a good lecture. And thank you for giving my colleague the platform to express himself. I know you are all pain experts, so I'm sure we can also learn from you. Thank you very much.
Thank you very much, Madam Prof. Okay, so once again, we appreciate you, Dr. Ameye, for the scintillating lecture. And I'm sure people will have one or two questions. Please, you can type your question into the chat box and we will read it. Or if you want to ask a question, you can raise up your hand and we will call you to do this. So, but maybe I can just start with my own small question that how do you cope with diagnosing pain in pediatrics? That's a head and neck pain. Dr. Ameye, I'm not sure you are. We can't see. Okay.
I'm with you. I don't know. Okay, let me just. I know the audio was quite bad, but I try to highlight that it's one of the challenges because you may not know what is causing the pain, but the only remedy is your further assessment by examination. You know, generally in that region, it's challenging to really locate pain until you examine the patient, because patient will tell you the way they perceive the pain, where they think it's coming from. So in pediatrics, you may have to examine. Maybe the child is irritable and you look in the hair, you may find out child has otitis media, which is causing the pain. But you may not, a pediatric age group may not readily express pain in a way that can really help you. So that's the challenge we face, and the remedies to examine and try and understand what could go wrong in this location.
Thank you. So do you also manage cephalgia and other pain in the head region?
Not really. And it's I see this diagnosis with regular because I work with neurosurgeon and they get this diagnosis. But where they come to hear is that some of them will not have vertigo because of course, so they are linked together because of the affectation of the blood supply to the labyrinth. So they come to me, and whether somebody comes, an elderly person comes, vertigo, and asks, do you have neck pain? Then I send to our neurosurgeon or do some investigation, maybe we'll find some pathology or send to them. So that's what happened. But we don't manage readily. And that's why I say it's a bit challenging for us to talk about pain in ENT.
Yes.
Okay, thank you. Thank you very much. Please, you can raise up your hand if you want to ask questions so that I won't be the only one asking him. I'm so impressed with the referred pain. And I think you mentioned about this stent. So how common is referral of pain in the ear, nose, and throat?
Actually, it's actually referral pain is even commoner than the pathology or ear pathology itself. At least from my little experience, referral pain is common. In fact, the first thing when I'm examining is not like I explained to you. You need to prove to the patient that this problem is not coming from the ear. They come to you with ear pain and you examine and you don't find anything. So referral pain is quite common. It's quite common. It's not. It's quite common. Patient will present with ear pain based on pathology in other region of the ear and neck.
Wow. And I think the most one that really struck me most is you have pain in your abdominal region, and then you are feeling it in the throat.
Yeah, I didn't say abdominal. I said thymus. I think thymus was my lowest organ there.
Okay.
Thymus.
Okay. And do you have issues with autoimmunity and then pain in the ear and nose?
Autoimmune hearing loss is all I can think about, but I don't think the main presentation will be the pain. Maybe the other thing that can cause pain, maybe some not autoimmune. Some patient can come with most evident pathology that can show, of course, anything that can affect cartilage will affect cartilage of the ear. If it's autoimmune, you see it and see the pathology. But rarely do I have to think about that diagnosis of autoimmunity and head and neck region.
Yeah, I think I asked that question because of we talk about myasthenia gravis and the thymus being kept till adulthood and what have we.
Okay. Oh, well, I have not. Maybe I've not seen somebody walk into the clinic that I'm thinking about autoimmunity, but I'll keep that in mind.
Thank you. So please, we have your question, raise up your hand or send in your chat message. And my final take is, did you generate that chat flow on Otagia and did you do this? The flow chart.
Right.
Sorry, we are not hearing you.
I designed the flow chart based on knowledge. I tried to prune some other pathologies away, but I designed the flow chart.
Wow.
I think PowerPoint is quite easy to do in PowerPoint.
Wow. Okay, so now because we are recording and then this will go to the YouTube, will have been nice to have said maybe put below it and say designed by you, and then we know that you are the first to do that design, and it can be referred to.
Not all people have designed algorithm based on management of or referred or pain in the ear. It's not hidden knowledge or it's not a new knowledge. Only thing I try to do is to design from scratch and based on my own experience, add one, remove some other things. So no need to put. It's just the way I think when I see patients. That's why I try to put on the slide. There may be some other diagnoses that I am missing that I didn't include. And remember, I need to keep this within the context. I know this is multidisciplinary assembly. It's not just, I try to keep everything as simple as possible. So that's why. So,
okay, thank you. But it's still like you modified it or something, you assembled that chart. Thank you very much. Professor Umwaso, you have something to say?
Good evening, everybody. I'm just to congratulate the presenter for today for the brilliant lecture, and yeah, to agree with him that it's actually a difficult area, more or less, and to say that I think we need to do a little bit more about head and neck pain, because I know that we did some things with the maxillofacial and dental surgeons about the difficulties in diagnosing this pain, in treating it, in the assessment, and especially when you have some cancers that give very difficult, painful symptoms, pain symptoms that are difficult to manage. So I'll just thank the speaker and to say that maybe as an association or as a society, we should look at seeing how we can develop some care, simple assessment protocols or algorithms that are peculiar to us as Blacks and as Nigerians. And maybe that will help to answer some of the questions about the difficulties in managing this kind of pain. Once again, congratulations, Dr. Sanyolu, and I think we will need to talk more later about the work that is left to be done. Thank you very much. Well done.
Thank you, Professor Nwaso. Dr. Adeda, for a long time, can you just let us hear from you?
Good evening, sir. My president, my teachers, and colleagues on the platform. So sorry. At times, you would have almost rounded off before I'll be free to join. Today, now, I've had difficulty joining, and I tried over and over again. Dr. Sanyolu, I want to say congratulations on your presentation. Thank you so much for being a part of this. And some part of it, I couldn't get them because the network locked me out. But let me say this, peradventure you didn't say it. I also experienced during my training outside Nigeria that certain nuclei in the brain within the skull can be blocked, or some neurolytic agents or post-radiofrequency ablation could be done to them as part of a way of controlling pains around the head and neck under fluoroscopic guidance. My trainer then did some. Since I returned to Nigeria, I've not been able to practice in that direction. But there are some people who are gurus who can go with needles through some foramina in the skull under fluoroscopic guidance, block some nuclei, and that confers a lot of pain relief. In fact, the exit of the trigeminal nerve just in front of the hair there will also be a point where that is easily accessible to most people, but people have to be careful again because, the trigeminal nerve emerges from there, dividing into three, the ophthalmic, the maxillary, and the mandibular branches. And this could also serve some subcutaneous pain relief at some points. I think I should mention that for the younger ones who will have better opportunities to be exposed to this, there are a lot of frontiers that are yet to be conquered. My president, thanks again for calling me out. Thank you, sir. Over to you.
Thank you for this contribution. Maybe I will just take you on the little and ask, and these fluoroscopic guidance and needles and what have you, do we have centers in Nigeria that can do that? I remember I posted something about spinal cord injury and pain control on our website. Somebody was asking from the UK and nobody has responded. So do we have any centers in Nigeria that can do this? Dr. Adetapo?
I'm not too sure. I think Dr. Sulaiman, Professor Sulaiman may be able to speak to that. I just said it now that, some years ago during part of my training, I actually had some training on mannequins and on risk covered. They have a way of preparing their mannequins themselves and you could try it. But I've not been privileged to try that since I came back from that training. So I'm not too sure I can do that now. But in case I'm not sure. Maybe Professor Sulaiman could speak to that in case he knows anywhere that could be done.
Professor Sulaiman, please, over to you. Okay, we cannot hear from.
Sorry, I'm trying to learn to. I don't know if I can make one or two comments based on.
Okay, please go ahead. Please go ahead.
Okay, and thanks, Professor Elizabeth. What you have said about pain in the head and neck region is true. There are more need to be done. My go-to resources, I just decided to, while I was preparing, let me search this Otorhinolaryngology Clinic of North America, because when they pick an issue, they discuss it to the end. And volume 36, issue number 6, was about this, about pain in the head and neck, and so many dimensions. Like I said earlier, to look at it from perioperative, from even up to acupuncture was discussed. So there actually works, like you have said, but we are not focusing on it, and it's nice to look at it. And the same vein, I told the Dr. Adetoye, I try to avoid talking so much about this. I came across all this that we talked about and felt like, well, I think that you are the expert in that area. We send consultation to you that we have this pain intractable that we cannot control. So I didn't want to talk about it, but there are resources on this. And like I said, when I opened this Otolaryngology Clinic of North America, that particular volume was devoted to that. And I could see a lot of images that look like what you are talking about, actually blocking the pain at the level of the neuron in the brainstem. So thank you.
Thank you very much. Professor Akinpelu, have any comment before I hand over to Dr. Olateju?
I just want to congratulate the presenter. I have been well educated. Thank you very much. And I wish you all the best in your sojourn in Saudi Arabia.
Thank you, sir.
You're welcome.
Thank you. Dr. Olateju, are you there to round us up?
Thank you. Thank you, my president. On behalf of our president, SSPN President Professor Oyele, we appreciate our guest speaker of today, Dr. Sanyaolu Ameye. Thank you for the brilliant presentation. I must also appreciate professors in attendance. We have Professor Olaitan Soyanwu, the first SSPN president, who recently celebrated her birthday. We also have in the house Professor Ike Ajayi, a former SSPN president, Professor Ronke Akinpelu, immediate past SSPN president. We thank you for your for being with us. I also appreciate my president, Professor Elizabeth Ogboniwaso, former NST president and currently the president of Society of Obstetrics and Anesthesists of Nigeria. We also appreciate a teacher of teachers, Professor Yebisi Amusa, who's also a professor of head and neck. I don't want to break my teeth by calling Otorhinolaryngology. We appreciate you, Doctor, and other professors in the house. Dr. Sulaiman, we appreciate you. We appreciate Dr. Yinka Yelade and Dr. Adedapo Adetoye, who were former SSPN president. I can also see our president, NSC president, Dr. Busola Briggs. We appreciate you. We recognize all the nurses, physiotherapists, medical doctors, veterinary doctors, and other professionals in the house that you cannot be mentioning their names one by one. We say thank you for your attendance and your patience in this meeting. We hope that next month, which is our conference, which will take place in Benin City, we also wish that some of the people in the house who want to join us. It's going to be hybrid, virtual, and physical. Please take time and join us in Benin City. That is next month. Maybe my president would like to shine more light on the SSPN conference coming up next month in Benin City. Once again, we appreciate you all. Over to you, my president.
Okay. Thank you, Doc. That's our vice president. Sorry, that's our vice president too, for the kind of vote of thanks. We have our conference coming up at University of Benin in the last week of July. And we encourage every one of us to attend, and there will be the third lecture, and it's an annual lecture, and that's where there are opportunities to submit abstract and to make presentations. So we encourage every one of us. Those who are not members of the SSPN, please try to join. We also have a African Pink Camp that the advertisement have gone on live on the IASP platform, and Nigerians are also qualified to attend. So please make use of these good opportunities. Thank you for attending this webinar, and until August, because traditionally in the month that we'll have our an annual conference, we do not have a monthly webinar. So until August, when we'll come up with another new presentation, we want to thank Dr. Ameye and everybody that have participated in this evening's webinar. Do have a good night rest, and thank you.
Good night, Mr. President. Good night, everybody.